In a world that's having lots of conversations about sexual exploration and gender, are we getting better at speaking about sexual trauma? Welcome, gyno-curious listeners. I am Dr. Amy Novat. We are here to investigate what it means to be a healer and to be healed. Today, I am so grateful to speak with Dr. Holly Richmond, a somatic psychotherapist, certified sex therapist, and an international health and wellness coach. A true healer. Welcome, Holly.
Hi, Amy. It is so wonderful to be here. Thank you for having me.
It is my great pleasure. You have written a terrific book called Reclaiming Pleasure, a sex-positive guide for moving past sexual trauma and living a passionate life. There are not too many experts who would use trauma and reclaiming pleasure in the same sentence. How did this become a focus of your work, Holly?
Amy, that is so true. And I hope it's changing, that we can hold trauma and sexual health in the same container. So I got my master's in clinical psychology in California. And in the state of California, you have to do 3,000 hours of internship. And I did almost the entirety of mine at the Santa Barbara Rape Crisis Center. So I was, really immersed in the world of sexual trauma, and going through those 3-4 years and talking to the clients, I realized I had been trained very well in treating trauma, but I didn't know how to treat the what comes next. And that what comes next to me is healthy sexuality, solid relationships, and really being able to move through the world in a safe way, but also a pleasurable way.
So let's just start with, sexual trauma means different things to different folks. So what is your definition as we move forward in our conversation this morning?
Yeah, it is. It's a very vast definition. So sexual trauma in general, I love Peter Levine's definition. It's too much too soon. It's the absence of an empathetic witness for the shame we are holding. In Reclaiming Pleasure, I really walk through the different definitions of various kinds of sexual traumas because it is very important to me that we know what happened to us. Words inform our experience. So someone who experiences childhood sexual abuse is going to have a different survivor experience than someone who has experienced date rape, spousal abuse, gender violence, things of this nature. So really understanding what happened to you is a huge piece of this. And my last definition for sexual trauma is this. It's that it's violating, not necessarily violent. And I think that is still where our culture goes wrong. So violating, not violent, because movies, TV show us, someone's hiding in the back of your car or someone jumps out of the bushes. That is not how most sexual trauma happens. So over 85% is perpetrated by someone known to the survivor. It's not the person in the back of the car. It's not the bushes. There are rarely bumps or bruises or scars. This is an internalized experience, which I know, Amy, we're going to get to shame, but that's where it starts.
Yeah. What is the incidence of this phenomenon? People are going to say, why is Dr. Novat speaking to Holly about this issue today? Let's put it out there. How prevalent is this problem?
Yeah. 1 in every 4 women, 1 in every 9 men will experience some form of sexual trauma in their lifetime.
Thank you for bringing out the fact that penis havers are also victims to this crime. And we often, I think, diminish the value and impact of this phenomenon when we just talk about vulva havers, because we still live in a world of patriarchy. We still live in a world where shame is associated with this phenomenon. But when we start to broaden it and realize that it is a universal phenomenon for all human beings, that elevates its importance, unfortunately, but it does in the world of TV shows and virtual stuff.
Can I add one more statistic for your listeners?
Absolutely.
Because, okay, so 1 in every 4 men, 1 in every 4 women, 1 in every 9 men. So then we've got our transgender and non-binary folks. They experience sexual trauma at 66% higher than that. So we're going to say most. most people who identify as non-binary in some way are going to have experienced sexual trauma.
It's daunting. It's just
Yeah.
daunting. And I don't know about you, but I've been working in the world of, GYN for a long time. And each and every time I hear this statistic, I am breathless. Yeah. Do you think we are better at discussing this issue since, for example, the Me Too movement? Are we talking about it more?
I think so, but here's where I land on that. I think our younger generation, so our Gen Zs specifically, they're going to have an easier time identifying it and talking about it because of all the media attention with the coaches and the actors and the people that have been kind of chronic perpetrators. They now know, hey, that's not okay. However, the people I see most, so the millennials, the Gen Xers, and even baby boomers, they're still in the spot of, I don't think what happened to me was bad enough. I don't think I count. I couldn't call myself a survivor because you know what? I think maybe I had something to do with it. I'm sure it was a little bit my fault. All of these erroneous stories that survivors tell themselves.
Yeah. And as I think we both know, it sometimes takes or often takes years for people to come out with this story, to recognize that this is a part of their history. In a world that quantifies everything, what do you say when someone says, my experience wasn't as bad as hers, so maybe it isn't really trauma?
I say we don't get to measure suffering.
Huh. Yeah. That is really hard for all of us, given the world in which we live.
Right. It's so much easier to make someone else's worse than ours than I can minimize mine and put it on the back burner. Amy, we're probably going to get into this, but a little piece of was it bad enough? So how I look at was it bad enough is in four quadrants. So there's emotional, physical, relational, and sexual. There's a chapter in my book, chapter 6 is all about hidden wounds. That seems to be the most powerful chapter because people open that up and they can see themselves 2 or 3 times in all of those different quadrants, right? So if you're moving through the world and your body is expressing in ways that aren't comfortable, you're having trouble with relationships or sexuality, maybe your trauma was bad enough, right? Maybe your body's saying it. Maybe your relationships are saying your sexuality, that we don't just have to rely on what we think and try to minimize.
I've heard you speak about how to differentiate victim from survivor. Why might this distinction be an important part of healing from trauma and moving towards reclaiming pleasure?
Mhm. So in my training, I was taught to use the word survivor instead of victim when I'm in a therapeutic space with people. And just imagine this. You're my client and you're sitting across from me and week after week. And I say, as a victim of childhood sexual abuse, you're going to feel this. Oh, and because you were victimized and you did this, like you can kind of feel how heavy and almost hopeless confirming your victimhood. Versus when I say a lot of survivors of sexual trauma experience that. And because of your survivorship, you might face some of these challenges. So it just kind of pivots the tenor that's in the room.
It so does. And it reminds me how volatile and impactful words are. And we all have these stories in our head. And if the story in our head is always about the victimhood, being a victim, and then the therapist you're seeing, or the doctor you're seeing, or the clinician you're seeing, or the world that you're in is always using those same words, man, is it hard to, as you say, pivot to a different role in that story.
Right, right. So first we've got to get from victim to survivor, and then we've got to get from survivor to thriver because really start my book with surviving isn't enough either. I don't want people to just move through the world to get by. I want them really living it and embracing it. One more note on victimhood. So, of course, that feels a little bit more hopeless. I meet people sometimes who are very much in that victim space. And it will be hard to pull them out of that, but it's work I enjoy. So they might be the people that aggrandize the trauma and say, this happened to me. It was the worst ever. I'm never getting better. I'm angry at the world. And that's okay. You can be there as long as you want versus the typical client I'm going to get, the one that can kind of wrap around her head around survivor just barely. She's going to be the minimizer. She's going to say, it wasn't really bad enough. I'm not sure that I can get on board with this. So it's two very different. One is holding on tightly, and one is like, I don't want to think of myself that way.
Again, we all have a different way of telling our stories and the way we want to be heard and seen. And so your work is so much about having a capacity to kind of telescope in and out and understand the nuances, the obvious, interpreting all of these different ways in which we express our lives, right? Yeah.
Yeah.
Yeah. So again, I want to just remind our audience, I'm speaking with Dr. Holly Richmond about her experience as a sex therapist and somatic psychotherapist about healing after sexual trauma. So earlier we were beginning to talk about kind of the mind and the body. And certainly in my work, I'm always thinking about how the body, or what I call the soma, and the mind or the psyche communicates with each other and with the individual person. But often my patients are unable to make a connection or interpret the physical symptoms with an emotional one. How do you guide patients through the process of understanding how the mind and the body communicate with one another?
Mhm. Amy, like your work, but you're a hands-on practitioner. I'm not. I'm going to bring in all of you people like you and other hands-on body workers to facilitate this process. But I'm going to start with the body and symptoms and sensations. Most often, a survivor is going to come to me with some kind of somatic manifestation of trauma that they're not going to understand. And nothing against people in your profession, but they've most often been to doctor after doctor after doctor, and the doctor minimizes and says it's all in your head or some version of you're crazy, you're not in that much pain, or no, that's not what's really happening. Right. So my job is to validate that experience and start stitching those somatic expressions together. And again, they can be relational, psychological, sexual, or physical to create a story that they can tolerate.
And speak to me about how the survivor comes in, and some will have somatic complaints. Others may say, oh, my body feels fine, but man, I can't get out of this dream or this nightmare that I'm having each night, or I'm crying all the time, whatever the manifestation is. So again, you describe these different components, but I would imagine every patient who shows up in your office has a different array, if you will, of those components.
Absolutely. And some are going to lean more into the psyche. They're going to be very head based, very much in their head. But Amy, you can imagine what kind of sex those people have. It's not going to be so great because they don't have access to a lot of sensation or feelings. And if they do have access to it, it's hypervigilance, it's pain, it's way beyond anything they can tolerate, or it's numb. Right. So usually the person that's in her head is going to say, I just don't feel anything during sex.
Or they'll say, oh, it's fine, quote unquote. That is the standard answer I get.
Yeah.
And you bring out something that causes me some level of shame when I hear from so many women who come into my office around how no one has ever asked them about sexual health, pleasure, or history of abuse. And we know science has demonstrated that allopathic physicians, maybe 20% will ask any questions about this issue. And then when they ask the question, it's usually just checking a box and going on. So there's no exploration, no room for a conversation. So it's no wonder to you and to me that women are holding on to these storylines for years after talking to doctors, right?
Absolutely. And Amy, I so appreciate your approach and just opening up that conversation. And then, I think you and I both stay in our lanes, right? I can see in a client where I'm like, okay, this is a gynecological issue, and I'm going to refer her out. Or for you, I'm sure in these discussions that you have before an examination, if you feel like something's there, then you're going to point people to a therapist that could hopefully help.
Right. Our job is so often about just affirming and hearing and seeing and letting people know that what they have to say is important and valuable. And I'd say to our audience that with that in mind, You don't have to tell your whole story, do you, Holly? Do you have to reiterate, detail by detail?
Not at all. Some of my most profound cases, I never knew the details of what happened to the person.
Hmm.
I do not need to know the details. No one needs to know the details of your story. For some people, that's going to be a crucial part of the healing, kind of unburdening themselves as the sole holder of those secrets, those details. For other people, it's just too hard and they don't want to share those. Both of these experiences are perfectly valuable. One is not better than the other.
What would you say to the therapists who are listening to us about why it's important that they don't have to hear those details? What can they do with that therapeutic approach?
Yeah. Attunement, building rapport, validation. Um, most trauma therapists are taught to have breaks. So, and I think many therapists who don't work in trauma or the sexual realm don't understand that. So a client sits down and we start pulling out the stories. But when someone has experienced trauma, we have to have our break before we have the gas. And I think after, 15 years of doing this, my process can go pretty slow, right? Because I'm not going to want to get ahead of the client or have them share too much and then they're re-traumatized and then we're way, way back. So this is a very slow, deliberate process. I'm watching for body language. I'm watching for patterns of speech, blinking, all of these things. So we're going at the client's pace. It's the very Bohemian, meet the client where they are, not where you are.
I'm so pleased to know that in your environment, you get to spend that time. Again, one of the things that's happening in the medical world is that patients have so little time with their clinicians. And as the world of medicine becomes more and more about investment bankers and financiers and less about healing, I have to remind our audience that if you're not getting what you need from your clinician, then you need to look further. How would, in fact, you guide folks around finding the right person to talk about this with?
As far as an OBGYN or a sex therapist?
Well, I guess a sex therapist, because that's your world.
Yeah, or a trauma therapist.
Yeah.
So I'm going to be curious, what are they interested in? Are they a person who appreciates like kind of the heady, the science? Do they want a therapist that knows all this just statistics and research? So I would point them to a cognitive behavioral person. Or are they very spiritual in their approach? So then I might send them to someone who studies Tantra or is very kind of spiritual and brings in a lot of five senses work. Or if they're very much in their body, if they're a somaticizer, which so many of us are, and I'm raising my hands here, I'm going to point them to a somatic person that is every time that they come in at the end of the session, they're going to get homework that is body based. Sometimes that homework is going to be not sexual whatsoever. And as they progress, it's going to get more and more sexual, most often with themselves, or if they want to bring a partner into that experience, of course, we do that as well.
Yeah. So let's pivot a little bit. So pleasure. What does pleasure mean to you? Is that all about just orgasm or is there something more to it?
Yeah, there's so much more to it. And probably one of the most impactful things that I do with survivors of sexual trauma is help them understand they never have to say yes to a sexual experience that they don't want ever again. And I really believe that. So I'm thinking of several women who their abuse included penetration. And at this point in their lives right now, they're like, I just don't like it. There's nothing about penetration that turns me on. I get triggered. I've tried. I don't even like how it feels. And then I get to say, you don't have to do that because there's about, I don't know, thousands and thousands of other things on the menu that you can do. For some people, orgasms are the be all end all and they love them. For others, survivors in particular, they're going to be very, very scary because orgasm, le petit mort, right? The little death, we're quite out of control when we're having an orgasm. And obviously, from a trauma informed approach, being out of control is not going to be a favorite thing for most survivors.
It's a moment of sheer vulnerability, isn't it?
It is.
Yeah.
It is.
I will sometimes say to patients who are struggling in their sexual health, I talk about how just holding hands can be the sexiest thing out, and that everyone gets to define for themselves what gives them pleasure and what sexy is. And that for many people, it's about re-exploration, starting from just touching. It doesn't have to be, again, about penetration from the get-go. Yeah.
Yeah.
So, Holly, there are many, many, if not maybe most people, whether they're in your arena or mine, who just really don't know how to speak about sex. What allowed you in your personal experiences to get to a place where you could clearly talk about it all?
Oh gosh. Amy, it was one of those moments. So I didn't go back to school for my master's until I was 38, my doctorate when I was 40 something. So I was a journalist for 15 years before that. And there was a pivot point, which we don't need to talk about. But during that time, I looked at my bookshelf. It was filled with books on sexuality. So especially stories or sex, I had not put two and two together. So I've always been interested. And being a new sex therapist, it is hard because I certainly wasn't taught to talk about sex. I wouldn't say I grew up in a sex negative household, but it was, I was born in the 70s. So it was certainly, my parents weren't talking about it a lot either. Um, it is, it is pretty cool. And just to see clients' face, because I will just roll it out at this point because there's nothing to be ashamed of, but that's a built skill. And Amy, I'm sure you can tell us like skills that you've built over the years that were kind of scary or you were a little bit tentative about when you first started.
My patients are sometimes astonished at the language that I will use around sex. Do you think that there's some value in kind of diffusing some of the social contours around this language?
I do. We need to normalize it. I always say sexual health and our overall health are not dualistic. They're one and the same. This is one body. There's not sex over here and me over here. It's me and my sexuality. And you can prioritize it as much as you want, or you don't have to. Even for someone who is asexual, that is a choice. That is not by omission.
Right. You're talking about integration. You're talking about looking at health in a very global fashion insofar as it incorporates our intimate lives, our outer lives, our work, our psyche, our soma, kind of the whole picture. And so often folks they'll disentangle or they'll dissociate sexual health from their overall health.
Right. And especially if you're a survivor of sexual trauma, that's actually a pretty elegant solution for a while, right? These are smart people. And that's part of what I confirm for them. Like however you chose to cope with this. At one point it was adaptive. And then throughout the years, it became maladaptive. And now you're at a place with an awareness that, oh my gosh, this isn't working for me anymore. Right. So then we have to come up with adaptive strategies. No one it chooses to have things that don't work for them. It starts as a way to either avoid or numb or minimize, like that's all, so whether it's substances or avoiding sex altogether, eating disorders, oh my gosh, it's the rate of eating disorders in people who have experienced sexual trauma is very high, again, because eating disorders are not about food, they are about control.
Yeah. Yeah. Is there a typical age in which women will start turning, where the mind will begin to say something needs to be excavated here? There's something going on.
Amy, that's a hard one. And back to one of your original questions, I think women are coming to it sooner. I'm going to give you in my practice. I'm not saying this is a global perspective, but in my practice, it's 35 to 50. When they're like, something's wrong. Sex isn't working for me anymore. And Amy, I could be totally wrong here, but again, like 38 to 43, I feel like so many women I feel like it's a sexual prime for a lot of women. They know what they want. tell me if this is right or not, but their body is kind of in that last ditch effort of like throwing eggs everywhere and their hormones are up. So I feel like there's an evolutionary biological process here as well. But I also think it's confidence, it's time of life, all of those things. But that 38 to 43, I'm not saying that's when they disclose most of the trauma, but it's women who come to me and like, I want to have good sex and I deserve it.
I totally agree. There is these moments or these years, as you describe, where women are really, the expression that we often hear is, coming into their own, which for whatever that's worth, it's really about the combination of biology and sociology and if one chooses to have children, where you are in child rearing, kind of the global, the place we are in our global world. And it is often a time where women are beginning to say, I want to feel lust. I want to feel pleasure. I am not. What is going on? Because everyone else is.
Right.
Yeah.
And that's so hard. Everyone else is having great sex and not me. Obviously, you and I know that is not true. And you and I both want more people having better sex. So my hope, I mean, this is a great time of life for most women, but if women can catch up sooner, that they deserve to have great sex. And again, I think Gen Z is on it.
Yeah.
I think they are very on it.
Yeah. They're talking about sex and gender and fluidity in a way that certainly I never had as a teenager or in my 20s. It is really exciting. Yeah.
It is.
But again, I want to point out for those who are older, that doesn't mean you necessarily have to have the same language. It doesn't mean you have to have the same access. It's really about finding the right person to speak with.
And you can have great sex in your 50s, 60s, and 70s. I'm seeing more and more people in my practice at that age. And that just lights me up because it's just not true. I mean, Amy, to me, that menopause means you're not having great sex. It actually means the opposite for a lot of my clients.
Absolutely. So even if there are physical changes like vaginal dryness and the need for assistance with that issue alone, which happens to many, many, many women in their postmenopause, doesn't mean that you can't find routes to pleasure. And again, Holly, I'd like you to articulate when you use the word sex, tell the audience, what do you mean by that?
I mean by that what you mean by that. So one of my favorite things to do is help clients discover their sexual template. And I break that down in two ways. So there's desire and arousal. So desire is the psychological process of wanting, arousal, the physiological process of wanting. I will walk my clients through both of these columns with the five senses to really figure out what they like, what turns them on. And again, sex is not penis and vagina. Sex can be penetration. It cannot be penetration. It can be so many things. So it's just brilliant to take clients on that ride.
It is so empowering for people because, again, if you've been brought up in the gender binary and in the concept that penis and vaginas and penetration is the ultimate and only end result, to break through those barriers is just so exciting and wonderful and hopefully healing for everyone out there.
Yes. Beautifully said. Thank you.
So, in your work, you talk about surviving to thriving and the power of eroticism. How does Eros play a role in all this?
Eros is it. Eros is it. So I want you to have great sex, but I want you to have a great life as well. So when we look at the term eroticism or Eros, E-R-O-S, the literal translation of that is life force, vitality, vivacity, creativity, imagination, co-creation. There's nothing in there about sex. And we've, in our Western culture, if it's erotic, it's sexual. Sure, it can be, but it's just about you feeling alive. To me, alive is different than surviving, right? Surviving is I'm getting through, I'm doing okay. I might even look like I'm functioning fine, but there's nothing that's really lighting me up, bringing me joy versus thriving and eroticism, which Yeah, it just, the flow state, right? The flow state of just feeling alive, present, and in this world.
So, what you're pointing out again is that we all have different ways of experiencing pleasure and the life force. So, part of the work for all of us, whether we're survivors or not, and I'd like to point out that there's no one in this life who doesn't have some form of trauma, right? It may not
Right.
be sexual trauma, but there's trauma. What we're talking about is figuring out what makes you thrive, what makes you feel good, what gives you pleasure, right? Yeah.
Absolutely. Absolutely. And this might be body based, it might be artistic, it might be writing. I mean, there's just so many things. Sex therapy is just not talking about sex for a full 50-minute session week after week. We are going to talk about your life and find those threads to other things that make you feel alive.
Why are people so afraid of finding those pleasures? Meaning, if you were to ask the person on the street, what gives you pleasure? I think a lot of people would pause for a long time before they could articulate that. What do you think that's about?
One of the answers that is easiest for me is because our culture prioritizes productivity, right?
Mm-hmm.
How hard are you working? How stressed out are you? How little have you slept? Oh, none, none, none. That's great. So I'm going to prioritize you because you're really busy and really productive. The other piece I want to mention about pleasure, of course, it can be externalized. And there's a lot of wonderful things out there that are pleasurable, from ice cream to orgasms.
Mm-hmm.
And to me, when I'm working in a therapeutic setting, it's going to be on an internal experience of pleasure as well. Yeah. So there's nothing to perform for. There's nothing to be productive about. It's all right here. And I'm pointing to my body, right? It's all right here. So it can be an internal experience as well.
It's a fluid state, isn't it? It's not that when one feels pleasure, it's pleasure for 3 minutes, 5 minutes, 10 minutes, an hour, right? Let's help
Yeah.
folks understand that it's, again, I guess the best way of putting it is it's a fluid experience.
It is. It is. And it's having access to moments of pleasure.
Mm.
I honestly don't know anyone who moves through the world in pleasure all of the time. That's just not how we live. But if we can do the hard things, do the work, do whatever it is, the child rearing, and then prioritize ourselves. That's what women especially have not been taught. You deserve, I would love to say an hour of downtime every day, but for stay a mom who's working from home, that might not be pleasure, that she might not have access to that, but could she have 5 minutes? So it's prioritizing ourselves to be able to receive pleasure. That is where it has to start.
There's a great kid's story, 5 minutes piece, and it's this story about a mother elephant who just never gets away from her kids until she's in the bathtub thinking, oh, I'll get, an hour or whatever it is. And then the kids come marching in with their instruments and she's like, okay, 5 minutes will do. And I like telling or sharing that storyline with folks because it is sometimes all we need. I often tell women, in the middle of your day, fake it. You have to go to the bathroom? Great. Go to the bathroom, close the toilet lid, and just sit and breathe and give yourself a moment that's about you.
Right.
Yeah.
Right. And if you want to go a little bit somatic, you could sit, breathe, and do a quick body scan, right? From the tip of your toes to the top of your head. Notice where you're open, notice where you're tight, and breathe into those areas. And I think you will walk out of the bathroom stall feeling a little bit more fluid, flexible, integrated.
Yeah. Yeah. So we have to talk about shame because it is so much a part of our experience as women in the world, certainly with regards to sex and sexual pleasure, the world of sex workers, etc. I mean, it's a huge topic. But when someone comes in to your office and the first thing they talk about is, I feel shame, what do you say to them?
I'm going to be curious and ask some questions. And it's going to come down to whose shame is it? Because in sexual trauma, that shame gets misplaced almost immediately. And shame, again, I just want to, as context, and I know most of your listeners are going to know this. So guilt is I did something wrong. Shame is I am something wrong. Guilt, I made a mistake. Shame, I am a mistake. So what happens in most sexual trauma, again, because it's not violent, but the person knows, oh my gosh, that felt awful. Why didn't I scream? Why didn't I kick? Why didn't I, go through fight, flight, or freeze? Most survivors are going to be in that fawn or freeze. So most are going to freeze. It's exactly what it sounds like. They're going to dissociate. They're going to numb out, or they're going to fawn, which is go along to get along, say the right thing. They're going to say whatever they need to get themselves out of that situation to keep themselves safe. But if there's not this big expression of fighting back, yelling no, ooh, in goes the shame, right? In goes the shame. Is that their shame? To me, it's certainly not. It's the perpetrator's shame, but it just gets sucked right up by the survivor, right? Because what didn't I do? Why are we not talking about perpetrators? So, I mean, Amy, I don't want to get on a soapbox here, but we talk a lot about how many people are raped. Why don't we talk about how many people rape?
Right on. Right on. Why don't we shift the dialogue? Why don't we begin to focus on the perpetrators? It's a great question. And I think it's a part of the zeitgeist of our world. We don't talk enough about the, billionaires who are raping the country
Right.
of money, equality, the health of the earth, etc. And that is where we need to shift. And whether that's through rebellion or strikes, or in my world, I think everyone should give up medical insurance and just everybody should show up in ERs and just make the system implode. Because we're not taking care of people anymore, and we're not taking care of doctors or clinicians either. So the whole system is breaking apart. Yeah, but there are certainly a few people who are making lots and lots and lots of money.
Yeah, absolutely. And just one more point on talking about perpetrators. We know most perpetrators are male-bodied people, not all, not even by a long shot, not all, most. So I can say that, yet I'll talk to people and no one seems to know a male person who has ever perpetrated. Right? It's just not adding up, people. Amy, I get so angry. I'm like, I am going to go make a bumper sticker and stick it on everyone's car that says, don't rape people. Like, how hard is it not to rape someone? It shouldn't be that hard.
Oh, gosh, there's so many answers I could come up with, and the start is, as a mother of a young man, we start early and we teach our boys and girls how to respect each other. And I want to point out there are women out there who love women who are also perpetrators. So it's it crosses all gender boundaries, right? Yeah,
it does.
So, as we approach the end of our conversation, unfortunately, would you please summarize for the audience kind of what are the most common manifestations of symptoms concerning sexual trauma?
Yes. So again, you're going to look in these 4 quadrants. So physical, emotional, sexual, and relational. Physical is going to be some manifestation of physical pain. So the ones we see most are gastrointestinal. So IBS, there's something with the digestion that's not going right. In those questions, I ask, what can't you swallow? What can't you digest? And obviously, I'm talking big picture metaphorically here. There's going to be eating disorders. Psychologically, there's going to be a lot of anxiety, depression, anger issues, avoidance, insecure attachment styles. Sexually, and you know this so well in your practice, sexual pain, which we just still don't talk about enough because in my practice, I hear women say, oh, I thought that's just what it felt like. I'm like, oh my gosh, no. Aversion to sex or hypersexuality. And then on the relational front, that usually is some version of an inability to maintain healthy relationships Or if you are in a relationship, the boundaries are kind of all over the place. Spousal rape is a thing. So I still see that today as well.
So if I were a person who said, I think something's not quite right here, what would you recommend is the first step? How do you take what feels like an elephant on your back and figure out how to, gently get the elephant off? What are some of the first steps?
Yeah. So how I work my clients through this is awareness, understanding, behavior change.
Mm,
So, Amy, what you just spoke to is the awareness. That is a wonderful place to start from, just to knowing that something's not right. So, this is going to be different for every person. So, you can get a book on survivorship. You can look for a therapist. If you're looking for a sex therapist, there's two places I can point you to. One is Modern Sex Therapy Institutes, where I'm the associate director. So, we train sex therapists. And the other is ASECT, the American Association of Sexuality Educators, Counselors, and Therapists. I'm sorry, there's one more. And IBOS, the International Association of Sexuality Professionals. Or you can go to Psychology Today, and which is a huge search engine to find a therapist in your area. And there'll be boxes to check. And you would want to check sexual trauma or sexuality concerns.
And I want to remind our listeners that Holly Richmond has a great book with resources. So please look for Reclaiming Pleasure, a sex positive guide for moving past sexual trauma and living a passionate life. And like most books that can be quite triggering in a positive and challenging way, I would suggest to our listeners, start with one page at a time if you need to, or go back to the index and resources and look up only one of them, that it doesn't have to happen all at once. And that, as Holly has pointed out, that healing takes time and effort, and that there are ups and downs, and that everyone has a singular path in this journey. And that in spite of a more open conversation about sexual health in our world today, pleasure, and even the prevalence of sexual trauma, that finding that right person to talk to can take time. And so finding some patience around it, and taking those first steps is such a sign of healing and the start of this journey, right?
Yes, yes, absolutely. So, whatever healing modality you choose, whether it's a book, a podcast, a survivors group. By the way, I should have mentioned RAIN. Again, all of these resources in my book. Maybe, Amy, you're going to put some of them in the show notes. That could be great. So finding a local crisis center. If you're near a big city, most bigger cities are going to have a local rape crisis center or domestic violence and sexual crisis center.
Mm. So as I was thinking about our conversation today, I had to ask myself, what gives me pleasure? What does that look like for me? So I have to ask you, what gives you pleasure?
Amy, you know this about me, but I'm a late in life mother, and I'm just coming out of the very intense, phase of things. My boys are now 8 and 10. I only say this because I am all about differentiation, and I know that's a fancy clinical word. What do I mean by that? I mean taking time to myself to exercise, to go for a walk. Last night, I went out with friends and just sat at a beautiful bar and had a lovely martini. It's like the smallest moments where I feel like I'm indulging. And going for a walk and taking time to exercise shouldn't be an indulgence, but as a mom with young children, it's been missing. So I'm meeting myself again. I am meeting myself at this point in my life with a little bit more space and time, and it's truly been a pleasure. I'm so excited right now.
Thank you, thank you, thank you. Those moments of punctuated joy, that's what we're looking for. That life is hard for all of us. So finding those moments are what we're talking about. So I'd ask our listeners to just think about what gives you joy, what gives you pleasure. And the answers don't have to be at the tip of your tongue, but it certainly is something that you might think about through your day and through your life. So please, again, read Dr. Holly Richmond's book, Reclaiming Pleasure. It is a wonderful resource. I'm so grateful to you for writing this book and providing it to the world, really. Thank you, Holly.
Thank you, Amy. It was such a joy and a pleasure to be here with you today. And I love this podcast. Keep it up.
Thank you, thank you, thank you. So please join me each episode. And if you like what you hear, subscribe and follow us on whatever podcast app you're listening on. Thank you also to my listeners for joining me as we venture into the limitless conversations about our bodies and the world of OBGYN. I would love to hear from you. Please email your questions and comments to comments@radiofreerhiniecliff.org or call us at 845-307-7446. Also, thank you to my producers, Jen Hammoud and Matty Rosenberg. Until our next conversation, stay healthy and stand strong in your knowledge and your insights.